Good day, dear Professor Steffel. We say hello you from Azerbaijan, and it's a great pleasure for us. It's a really honor to have you with us today. And I believe that with this audience, where we have the leading cardiologists of Azerbaijan, we will have a great exchange on this very actual and important topic. And without further ado, I would like to pass the mic to the chairman of today's meeting, the president of Azerbaijan Society of Cardiology, Dr. Uzey Rahimov.
Hi, Jan Steffel. Hi, Professor. We are welcoming you. We are thanking you to join our webinar today, especially at the weekend. I want to continue in my own language. We have a simultaneous translator. All of my colleagues are interventionists, cardiologists, famous in my country. After my short introductory speech, we can listen to your presentation. Her şeyden evvel size profesör takdim edeyim.
Dear Professor, Dr. Uzey Rahimov is presenting you to our audience, our participants. Being a professor of University of Zurich, you are specialist in electrophysiology, specialized in interventional cardiology, in rhythm pacemakers and other very big and famous investigations. You're also the editor of several European journals. You're fellow and chair of European Heart Rhythm Association Education Committee. Today's meeting is dedicated to edoxaban as NOAC in treatment and prevention of stroke in AF patients. As you know, the AF incidence and prevalence is been increasing in the last decades, not only over the world, but also in Azerbaijan. That's why we can see many complications of that disorder. In Azerbaijan, the situation is also important and essential. That's why we are very keen to use the new type medications that show more safety pattern and mode in comparison with warfarin. We have certain experience in using NOACs, but also we are seeking the opportunity to use new generation medications. Edoxaban, I think, would be the good opportunity, would be a good tool to us to use it in our own clinical practice. Would like to give a word to you, dear Professor Steffel, to start your presentation. Here you are.
Well, thank you very much. Thank you very much indeed for the kind introduction. Thank you also for having me. Obviously, it's a great pleasure. And I would have loved to come to your country, where I've never been to before. That didn't work out this time, but maybe in the future, it would be my great pleasure and honor. Well, while we can't do that, I think it's a great opportunity to meet up like this. It's great to see many of you gather at your meeting. I'm looking forward to seeing people in person again. And as you just briefly mentioned, today's meeting is going to focus a bit on edoxaban. However, I will, of course, during the Q&A, I will be very happy to tackle any other questions. Obviously, also questions to edoxaban, but also any other questions. These are my disclosures, and I have been involved in many continuing medical educational activities over the last years with all of the NOAC companies. And I've been an investigator of the ENGAGE AF trial, which we will focus on today when it comes to edoxaban. Now, before we come to this, I think it makes sense to briefly take one step back and take a look at where we come from. Because currently in the field of NOACs, we are very frequently facing a situation where we feel that we don't have all of the evidence available for all of the subgroups and all of the special populations. But let's face it, this is the evidence that we had with warfarin, right? It was 6 trials and not even 3,000 participants across these trials. So really, compared to today's standard, this was minimal. This would not even qualify as a pilot study, let alone a study on which you would base a therapy on for decades. But this is what was done. This is all of the randomized trial evidence that we have with warfarin. It looks like it's pretty effective. It's a 64% risk reduction, which is obviously much more than with aspirin. And it was the only substance that actually reduced mortality in patients with atrial fibrillation. And then came the NOACs. And I know that you have seen these data before, but I think it makes sense to briefly remind us of this, because we tend to take these data for granted today, but it's everything but for granted when we take ourselves back 10, 12, 13 years ago, before the first trial, the RELY trial, came out. I think none of us would have anticipated that with the NOACs, we would be, as a class, even better than with warfarin. But you can see this, as a class, there is an additional almost 20% risk reduction for stroke and systemic embolism. And this is highly significant. On the flip side, none of the substances showed a significant increase in major bleeding. However, there were differences between the trials. And this is where the first heterogeneity turns up, right? This is not as homogeneous as for the efficacy. There were differences between the trial outcomes in terms of safety. And you can see that for dabigatran and rivaroxaban, there was a similar risk of major bleeding in their respective trials as compared to warfarin. Whereas for apixaban and for edoxaban, there was a reduction in major bleeding observed with the NOAC compared to vitamin K antagonists. Now, of course, we need to be careful when we are cross-comparing different trials, but ultimately, this is how the results came out. And these are mega trials. So we are talking about 14 to 21,000 patients per trial. So we have an evidence that is now over 70, over 80, almost if we count all of the NOAC trials, patients, right? So a huge evidence base that we are basing our decisions on today. And this obviously then had a big impact on the guidelines. These are the current European guidelines. I was one of the over 50 reviewers for this guideline. It's a huge document. But when it comes to anticoagulation, this is the main message. NOACs are the preferred therapy for stroke prevention. Class 1 recommendation, highest level of evidence. Now, you will notice when you take a look at this, this recommendation, NOACs are recommended in preference to vitamin K antagonists in all patients that are eligible for NOACs, for oral anticoagulation. So this also includes patients who are already on warfarin. This is important to remember because in the last guidelines before that, NOACs were only recommended in patients who are newly started on anticoagulation. And in fact, the guidelines go further and say that patients with on warfarin, especially those that don't have a good time in therapeutic range, these patients should be switched to a NOAC, class 1 recommendation. And why is this? Well, first of all, if we take a look at our patients on warfarin, we usually have this image in mind, right? We feel that we know the risk of bleeding goes up when the INR is over 3, 4, 5. We know the risk of ischemic stroke goes up when the INR is below 2, but we feel that there is a 0 risk in between. And this is not correct. In fact, when you take a look at it in a little bit more detail, this is from the Aristotle trial with the apixaban, but it's only an analysis of patients on warfarin. You can see that the vast majority, almost 80% of all intracranial hemorrhages actually occur at an INR level of less than 3. And if you take a look at other endpoints like major bleeding, GI bleeding, even stroke, you can see that the last INR value prior to the event is almost unanimously in the therapeutic range. So this is why the guidelines preferentially recommend NOACs these days, even in patients who are already on warfarin, because first of all, it's difficult to keep them in a good therapeutic range. We all know that. And secondly, even if we keep them in the range, there is a relevant residual risk for events, especially severe bleeding events. And this is why with the data that we have now, with the evidence that we have now, it is recommended to switch these patients, also these patients, over to a NOAC. And of course, we have 4 different NOACs available, and today we will focus a bit on the latest of the NOACs, and that is edoxaban. And there are some special features of this drug and also of this trial, which I would like to briefly touch upon with you. First of all, I should also mention that I was a part of the ENGAGE-AF trial. I have published a couple of the sub-analyses, but that doesn't change anything. I will briefly go and run you through the trial design. This was a bit special compared to the other trials. We had over 21,000 patients included in the ENGAGE-AF trial. With this, it is by far the largest of the NOAC trials. It had a 3-arm design, which is not the case for all NOACs. This is very important, especially when we talk about low dose and reduced dose of NOACs, right? There were 3 arms. There was the standard warfarin arm, then there was the high dose of edoxaban and the low dose of edoxaban arm. Now, this is very important to remember because there is frequent confusion about this. In the high dose of edoxaban arm, all patients received 60 milligrams of edoxaban, and this was then reduced to 30 milligrams. I will open this up a little bit here. This was then reduced to 30 milligrams in patients who had 1 or more of the dose reduction criteria that you see in the lower left-hand corner. So reduced renal function, body weight less than 60 kilograms, or concomitant therapy with a strong PGP inhibitor. If you had one of those criteria, you would receive 30 milligrams of edoxaban in the high-dose edoxaban arm. Now, the low-dose edoxaban arm, all patients received 30 milligrams, except if they had a dose reduction, then they received 15 milligrams. So here, essentially, both the standard and the reduced dose were cut in half. Now, what was seen with the low dose of edoxaban arm was that there was an increase in ischemic stroke by about 41%. And this is why this arm is not approved for use anywhere. I personally find this a bit unfortunate. I am very honest with you because I think this is quite an attractive evidence-based option for many patients, but it is not approved. Now, let's take a look at the outcomes of the trial. This is the Kaplan-Meier primary efficacy outcomes that we see here. And you can see that, in fact, with the approved high-dose edoxaban arm here, you have a reduction. Well, you have a trend towards a reduction in stroke and systemic embolism. Whereas in green, up until 1.5 years, it was completely the same as with warfarin. And then there was a trend towards more events. Statistically, this was not the case. If we then take a look at the principal safety outcome, and that was major bleeding, you can see that there is a substantial reduction in major bleeding with the approved, the high-dose regimen, as well as with the low-dose regimen, a massive reduction with the low-dose edoxaban regimen. Now, one of the misperceptions that we frequently see is that people say, well, you know, this patient qualifies for dose reduction, for example, renal insufficiency. But in this case, the patient would receive 30 milligrams in the high dose regimen, 30 milligrams because that's the reduced dose. But people feel that 30 milligrams of edoxaban is not efficacious. And that is a common misinterpretation of this trial, because if patients receive 30 milligrams because they fulfill the dose reduction criteria, Then they receive the high dose of edoxaban, and this is very efficacious. It's only in those patients where you have no dose reduction criteria. If you give 30 milligrams to those patients, which is off-label because it's not approved, then you're in the low dose regimen, and then there is a certain increased risk in ischemic events. I'll show you this even clearer in this graph here. These were stroke and systemic embolism in patients on warfarin in the trial. And you can see that obviously warfarin, there was no dose adjustment based on any risk factors. So all patients received the same warfarin and the same target INR between 2 and 3. Now, you can see that those patients that didn't have the dose reduction criteria, they had a certain event rate. And people who would have a dose reduction on edoxaban, but received warfarin, so for example, patients with renal insufficiency, they had a higher event rate, which is normal because these are the sicker patients. And now you compare this to the edoxaban. You can see that with 60 milligrams of edoxaban, there was a nice reduction in stroke and systemic embolism, and there was the same reduction also with the reduced dose of edoxaban, 30 milligrams. Now, the event rate, of course, is higher because these are the sicker patients. But compared to warfarin, there was exactly the same reduction in events. So 30 milligrams of edoxaban in the sense of dose reduction is a very efficacious therapy. And of course, the flip side is quite interesting because we see the same effect in warfarin patients also with major bleeding, right? Because these patients had the same target INR. But those that would have qualified for dose reduction on edoxaban, but received warfarin, those patients had a higher event rate for bleeding. That's normal. Again, these are the sicker patients, low body weight patients, renal insufficiency. So they have a higher event rate. Now, if we look at the 60 milligrams, there is a reduction in major bleeding. And if we look at the others that receive 30 milligrams, there's an even bigger reduction in major bleeding. So to summarize this, if you take a look at the approved dose of edoxaban, 60 milligrams and 30 milligrams in those patients that fulfill the dose reduction criterion, or one dose reduction criterion, then you have a very efficacious therapy with both doses and a huge safety benefit in those with the 60 milligrams, but even more so in those with the 30 milligrams. So it's a very efficacious and very safe therapy. Of course, not all of this is completely easy, and this is why we at the European Heart Rhythm Association, we put together this practical guide. I don't know if you've seen this before. If not, you can download this here for free. We just published this last April. And what this is dealing with really is kind of an adjunct to the guidelines. So whereas the guidelines really focus on all of the trial evidence and everything, the practical guide really deals with practical questions in and around NOAC therapy. And as you can tell here, we have gathered not only cardiologists for this, there is also neurologists, hematologists, internal medicine doctors, of course, and many others, even surgeons, that have helped write this guide. In the table of contents, you can see that there are a lot of topics that we cover in this guide, and I will go through some of these topics over the next couple of minutes. And of course, I'm more than happy to also tackle any questions you may have in this later than during the Q&A. First of all, and this is something that we frequently underestimate, not all NOACs are created equal. We have seen this before when we looked at the trial evidence, right? For the major bleeding, there were some differences between the different drugs, and there are differences. And it starts already with the metabolism. Now, I'm not going to go through this in detail, but just to mention that bioavailability, renal excretion, but also hepatic metabolism varies quite substantially between the different drugs. It starts with bioavailability. If you take dabigatran, only 3 to 7% will be resorbed. If you take rivaroxaban, almost 100% will be resorbed. But it's extremely important to realize, and also for daily clinical practice, that this is only achieved if patients take rivaroxaban with food. If you take it without food, you have about 1/3 less on board. And this is substantial. So if somebody, for example, doesn't eat breakfast, then they need to take their rivaroxaban at a different time point during the day. Because if they take it without food, they will not be correctly protected from stroke. They need to take it at a different time point, or they need to be on a different NOAC, because we have not seen this food dependency with any of the other drugs. Renal clearance is another important aspect. There are important differences between the drugs. You can see that for the dabigatran, which is a good drug, it's a very efficacious drug, but it's over 80% renally cleared. Apixaban is on the other side of the spectrum. It's only 27% renally cleared. And then edoxaban and rivaroxaban are somewhere in between. It's also important to remember, though, that the dose of edoxaban is cut in half, from 60 to 30, in patients with renal insufficiency, whereas the dose is only reduced by 25% with rivaroxaban, right? Because it's only reduced from 20 to 15 milligrams. So again, we will see later, this may give an advantage also to edoxaban in patients with renal insufficiency. And then finally, there are differences in the hepatic metabolism. You take a look at the dabigatran, for example, it's not at all dependent on cytochrome P450 metabolism, whereas there is some dependency for apixaban and for rivaroxaban. Edoxaban, on the other hand, is only minimally dependent on the most important cytochrome P450, and that's the 3A4 isoenzyme. And this also changes the way in which these drugs interact, for example, with other medications. And we'll touch on this in just a second. Just to briefly come back to the renal function, because this is something that we see so frequently in our atrial fibrillation patients. Now, you can see here the meta-analysis again of the NOAC trials in patients with reduced renal function. This upper panel here is in patients with a GFR of less than 50 milliliters per minute. And you can see that, in fact, from an efficacy point of view, you have quite a nice and homogeneous efficacy across all 4 NOACs. Now, when you take a look at major bleeding, again, it looks different. And what we see here really is the same image that we saw before in the overall trial population, in the sense that with apixaban and with edoxaban, you have a reduction in major bleeding, even in these highest risk individuals with a reduced renal function. Whereas you do not have a benefit in terms of major bleeding in patients on rivaroxaban or on dabigatran in their respective trials. Again, these are not head-to-head comparisons, right? But this is how the trials came out. And you can see that there were over 10,000 patients included with a reduced renal function. So this is a huge evidence base that we're talking about. And as a result of this, this is what we recommend in our EHRA guide for the use of NOACs in patients with reduced renal function. You can see that for the dabigatran, we advise for some caution in patients with reduced renal function. Again, I'm not saying that the dabigatran is not a good drug. It is a good NOAC. But in patients with reduced renal function, we need to watch out, or we need to switch to a 10A inhibitor. Now, the 10A inhibitors are available and approved all the way down to 15 milliliters per minute. Now, when we take a look at the pharmacology, when we take a look at the outcomes of the trials that we just saw, and we put everything together, we can, I think, make a point that edoxaban and apixaban will probably be the preferred NOACs in patients with renal insufficiency. Again, there is no head-to-head comparison, but based on the way that the trials came out, I think this is a fair assumption. Like I said, metabolism, on the other hand, is one thing that is frequently underestimated. And it is underestimated in the sense that we tend to forget that NOACs also may have drug-drug interactions. They have less, much less than with warfarin, but NOACs do have potential drug-drug interactions. And this is from our EHRA guide here. It's one of the tables. This ultimately drags on for another 9 or 10 pages or so. It's impossible to memorize this. And I'm not saying we should use necessarily this. If you have a good online database where you can check drug-drug interactions in NOAC patients, that's totally fine to use as well. I think it's important, though, to do it, especially in the older patients, in those with multiple co-medications, because there are potential interactions. And like I mentioned earlier, edoxaban was actually the only NOAC that was prospectively tested to be dose reduced in the context of certain co-medications, and that's in the context of strong PGP inhibitors, such as dronedarone, verapamil, cyclosporin, and I would ask to refer to the local label to see for which drugs this is the case. But this was not done for any of the other NOACs. And I think it's an important part because also the other NOACs, all of them, may be increased in the presence of certain co-medications. They also may be decreased in the presence of certain co-medications, the NOAC levels. So we need to apply some caution, and I think there is a certain advantage for edoxaban in this context because it was studied to be dose reduced in patients who have concomitant medications that may increase their levels. Now, of course, all of this is particularly important in the most vulnerable patient populations, and that is the older patients and those with multiple comorbidities. Now, I'm mentioning this because we frequently see this in daily practice, that we say, oh yeah, NOACs are good for stroke prevention, but in the older patients, I would prefer not to give them because they have such a high bleeding risk. And then people revert back to vitamin K antagonists, or they give aspirin, which is probably the worst of all options, because with aspirin, we really only do something good for us, for our own guilty conscience. We feel that we've done something, but the stroke prevention is really minimal, and the risk of bleeding is relevant. It's there. But what I'm showing you here is really the evidence that we have from the 4 trials, from the 4 NOAC trials, in the older patients, 75 years and older, and in younger patients, less than 75 years. And you can see when you take a look at the efficacy of the drugs, stroke and systemic embolism, you see a very similar risk reduction across all 4 NOACs in the younger patients. You see also a similar risk reduction in the older patients, but it's much more pronounced. It's much more pronounced than in the younger patients. So ultimately, if anything, from an efficacy point of view, being of older age is a good reason to be on a NOAC rather than a contraindication, because the effect is even more pronounced. I'm not saying that we shouldn't give NOACs to younger patients. I'm just saying that we should not deny older patients from NOACs because they benefit, if anything, even more. Now, again, of course, we need to take a look at the flip side, major bleeding. And for major bleeding, what we can see here is that in the younger patients, there's actually, again, quite a homogeneous effect across the 4 trials in terms of benefit for major bleeding. It's a little bit less pronounced, apparently, with rivaroxaban, but overall, it's pretty homogeneous. Now, for the older patients, 75 years and older, again, we see the same pattern as we have seen before, in the sense that for dabigatran and rivaroxaban, statistically, the bleeding risk in their trials was similar compared to warfarin, although the point estimate is really on the wrong side of the line of unity. So trending towards that in those older patients, actually warfarin may even be better. Whereas for apixaban and for edoxaban, again, even in these highest risk patients, there is a reduction in major bleeding. And like I said before, the disclaimer is always the same. These are not head-to-head comparisons, so we need to give a little bit of caution. But you see how there's a certain pattern emerging within or amongst these trials when it comes to high-risk individuals and especially the safety of the different drugs. And this was statistically significant. You can also notice that the evidence base that we're talking about here is huge. There are actually 24,000 patients included in the trials that were 75 years and older. There are over 3,500 patients in the ENGAGE-AF trial alone that were 80 years or older. So if you compare this to the beginning of what we mentioned with warfarin against placebo, the old trials, those were not even 3,000 participants. So you can make an argument that for edoxaban over warfarin, we have more evidence than we ever had for warfarin over placebo in the past. Of course, this is a little bit over the edge because these are different time points, when these drugs were studied. But the point I'm trying to make here is that even in the very elderly, we actually have quite good evidence for these NOACs, and with edoxaban being the largest of the trials, we also have the largest evidence in the very old patient populations. And a couple of years ago, we took a look at one other sub-analysis or subgroup of patients, which is similar to the elderly in the sense that they are frequently not well treated or that we shy away from treatment. And this is patients at an increased risk of falling. And I was personally quite intrigued by this patient population because we frequently see that these patients are not adequately treated. And in the ENGAGE-AF trial, it was actually quite unique in that we prospectively identified these patients. So before including the patient into the trial, for every single one of those over 21,000 patients, the investigators had to state, is this patient at an increased risk of falling, yes or no? So we're not talking about a retrospective definition. This was all prospectively identified, right? And there were actually exactly 900 patients in the trial that were at an increased risk of falling, which I think is good because these patients are also frequently not included in randomized clinical trials. And you can see that these patients, of course, were the high-risk patients, for almost every single category. They were older, they had a higher CHAT score, they had more frequently a history of stroke or TIA, they had more reduced renal function. Interestingly, their time in therapeutic range was actually quite similar in this randomized trial. Now, the outcome of these patients, I will cut this to the essential, the outcome of these patients was identical. So the benefit of edoxaban over warfarin was the same in patients at an increased risk of falling as compared to those without an increased risk of falling. However, what's even more intriguing and more interesting is because these patients had a higher absolute risk of events, their absolute risk reduction, especially for the most important type of events, was even bigger on edoxaban as compared to warfarin. Let me give you an example for this because I think this is really critical because it applies essentially to all high-risk subgroups. If you have a similar outcome in patients at high risk or low risk, then your absolute risk reduction will be bigger in the high-risk population. And this is true for edoxaban because the efficacy and safety of edoxaban was the same essentially across all subgroups that we studied. But if you have an absolute risk of, say, 1% in a certain patient population, and you reduce that risk by 20%, you reduce it from 1% to 0.8%, which gives you an absolute risk reduction of 0.2%, which translates into a number needed to treat of 500, which especially when you talk about severe events like intracranial hemorrhage is a relevant number if you're able to prevent one's intracerebral bleeding by that. But if you imagine now a high-risk population and you have an absolute event rate of 10%, Now you apply that same 20% risk reduction to those 10%, and you bring the risk down from 10% to 8%, which is the same relative risk reduction, but it's an absolute risk reduction. It's a 2% absolute risk reduction, which means your number needed to treat will only be 50 with the same relative risk reduction. So again, the same relative risk reduction will translate into a higher absolute risk reduction in high-risk individuals. So these patients benefit even more in terms of absolute risk reduction. So if you apply this to edoxaban now, the edoxaban, all patients benefited the same, but those at highest risk will benefit even more. That doesn't mean that we shouldn't treat low-risk patients with it because they also benefit, but it means we shouldn't shy away from higher-risk patients. And we frequently do. And that's why I'm showing this. And this is how I usually try and simplify this. This is the way that we think. And I fully include myself in this. If we take a patient, for example, the 75-year-old lady here, and we start anticoagulation and the patient has a bleeding, we feel that this is our fault. This is iatrogenic. We started it and now the patient bled. This is not entirely true, by the way, right? Because people usually bleed for a reason. For example, because of cancer, or maybe because of some other things like gum bleeds or hemorrhoids or whatever. But more importantly, if we decide not to anticoagulate and the patient then has a stroke, we should think the same way, right? But we don't. We feel that the stroke is not our fault, although we decided not to anticoagulate. So at least partially, this is our fault, but we don't feel it this way. We feel it's fate. So we feel that the bleeding because we anticoagulate is our fault, but the stroke because we did not anticoagulate is not our fault. And this is a misperception. This is a misperception. We need to be aware that if we do not anticoagulate, especially those high-risk individuals, and that patient then has a stroke, that's also due to us not doing it. And I think this is particularly where efficacious and particularly very safe NOACs come into play, because they can really help us. We have good evidence that the safety of these drugs is very good. We have included this in the EHRA practical guide in the sense that frailty, risk of falling, and so on and so forth, is not a binary phenomenon. It's not a black and white phenomenon. There are 50 shades of gray in between, if you like, or various shades of red, orange, yellow, and green. Frailty is not binary. There are those patients that are simply too frail to anticoagulate. And in those patients, we wouldn't anticoagulate. But the vast majority of patients is actually eligible for receiving anticoagulation. And especially if we have a safe and efficacious NOAC available, this is what we should do, because these patients, if they have a stroke, it's usually a disaster. They do not, well, a stroke is never something good, obviously, but if it happens in such a patient, it usually translates into a disaster. They never come back to their usual, their previous mode of functioning. And so this is really a clear message or a clear task for us to be better in terms of anticoagulation in these individuals. And this is also true for patients who are, again, who are on warfarin. I want to briefly touch on those again, because I also see this quite frequently. And I must admit, I fall into the same trap quite frequently. That if I see a patient, say, for example, a patient that is 80 years old, has been on warfarin for the last 6 years and has not had an event. My first reaction is, or used to be, well, never change a winning team. If that patient has been doing well on warfarin, just keep him on it. You can only lose. There's probably some truth in that, but there's also some false information in that. Because when we think this way, we feel that, or we need to think that the risk of this patient is static, that the risk today is the same as it was 6 years ago. And that's not the case. Patients' risks are dynamic. Today, if we see a patient today, and then again in 2, 4, 6, 8 years, their risk of stroke, but also their risk of bleeding increases quite dramatically. So coming back to the example, if that patient has been doing well on warfarin for the last 6 years, that does not mean that the patient will be doing well for the next 6 years, because the risk of events has increased quite dramatically. So it makes total sense to check back with these patients and check if a switch in anticoagulation may make sense. And that's true for patients on warfarin. It may even be true for patients who are on a certain NOAC, right? I mean, we have seen that there are some differences in the outcomes. For example, if I start a patient today, I'm just taking one example, which is an easy example, a patient on dabigatran with a renal function of, I don't know, maybe 55 milliliters per minute. And 4 years later, I see the patient with a GFR or creatinine clearance of 32. Just because that patient hasn't had any events does not mean that I should keep that patient on this drug. Again, don't get me wrong, dabigatran is a good drug, but once renal function goes down like this, we should be switching these patients just because they've always been on this, or just because maybe I only know one NOAC and I always use the same, is not a good reason to keep these patients on it. We need to apply some individualization, and we need to be courageous to also switch patients from one or the other agents if we feel that this is necessary based on the data. And the reassessment at periodic risks, that's actually something that's anchored in the guidelines. It's a class 1 recommendation to check back on these patients on a regular basis and then adapt therapy accordingly. I want to finish, well, almost finish, with a difficult topic, and one that may be particularly interesting to you, because as I've heard in the beginning, many of you are interventional cardiologists, so this is something you're dealing with, or it's something I think we all are dealing with quite frequently, and possibly on a daily basis. And that's the combination of coronary artery disease and atrial fibrillation. Because in these situations, we have the dilemma that we actually need to, on the one hand, apply good agents to the thrombocytic part of the pathway, but also need to apply plasmatic anticoagulants to protect these patients from stroke. Because as we all know, pure anticoagulation is not enough, especially in the acute phase of an acute coronary syndrome, but antiplatelet therapy is not enough for stroke prevention. And again, we're much further ahead in our knowledge today than we were 10 years ago, because we didn't have any trials with any of the NOACs for this specific patient population. Well, now we do. In fact, we have a trial for every single one of the NOACs. There are, however, some important differences between the trials. And again, it shows that not all NOACs are created equal. It also shows that not all of the trials are created equal. The Pioneer AF trial with rivaroxaban was the first trial to come out for these patients. It was a 3-arm trial, and it used vitamin K antagonists plus dual antiplatelet therapy as the standard of care, and compared it to 2 different dosing regimens of rivaroxaban. Now, first of all, this first arm here, the very low dose of rivaroxaban twice daily, this we can easily ignore, because rivaroxaban in this dose, this is actually the COMPASS dose or the ATLAS dose, is not approved for stroke prevention in patients with atrial fibrillation. So we can ignore, and it's also not brought forward for approval. So this arm you can ignore. The real pioneer scheme is the 15 milligrams once daily of rivaroxaban plus a P2Y12 inhibitor, usually clopidogrel. Now, importantly, as we all know, this is not the stroke prevention dose of rivaroxaban, because rivaroxaban is given at 20 milligrams, and it's only given 15 milligrams in patients with renal insufficiency. Whereas in the Pioneer AF trial, it was given with 15 milligrams to all patients. And in those with renal insufficiency, only 10 milligrams were given. So for rivaroxaban in this setting, we actually don't have a lot of data, because either we give 20 milligrams plus P2Y12 inhibitor, then we don't have outcome data, because this was not studied anywhere in these patients. Or we give 15 milligrams, but then we don't know what we're doing in terms of stroke prevention, because this trial, as all of the others, were underpowered for stroke prevention. So we don't know about stroke prevention. What the difference is with all of the other trials was that they used the NOAC in the dose that was tested in the large phase 3 trial. So for the REDUAL AF PCI trial, 150 milligrams or 110 milligrams BID of dabigatran were given. In the Augustus AF trial, 5 milligrams of apixaban, and in the ENTRUST, 60 milligrams of edoxaban were given. And for those two trials, ENTRUST and Augustus, also the same dose reduction criteria were applied as for the original trial. So this is important if we think about which NOAC we want to give in the context of an acute coronary syndrome or an elective PCI. Now, when we take a look at the outcomes of these trials, we can see that, not a big surprise, no matter which trial we look at, essentially, the risk of major bleeding is reduced. Overall, there's a very strong safety benefit, which is not a big surprise. If you combine a NOAC plus a P2Y12 inhibitor and you compare it to standard triple therapy, you would expect a reduction in bleeding events. However, interestingly enough, there was no difference in all-cause mortality, and there was also no difference in cardiovascular death. And this is somewhat contrary to what I would have expected, because in the past, what we have seen is that major bleeding, severe bleedings, in the context especially of triple therapy, is a driver of morbidity and mortality. But we couldn't observe that. We did not see this in any of the trials. So that means that the benefit of major bleeding seems to be counterbalanced by something else. And the one thing that this something else may be, in fact, are myocardial infarctions and stent thromboses. Because for both of them, there was overall at least somewhat of a signal that dual therapy, so NOAC plus P2Y12 inhibitor, might be a bit worse than triple therapy. So what this translated into, and this is essentially what we recommend in our EHRA guide, which is very consistent with the ESC guidelines, is that the main message is we can cut the duration of triple therapy quite dramatically. The one thing we don't really know in terms of trial evidence is how short is too short. And I don't think that we're in a situation that we can say that we can drop triple therapy in every single patient that comes in for a stenting, be it elective or acute. I think the cutoff of 1 week or 1 month, depending on the coronary risk of the patient, is probably a very good one. If you're talking about low-risk patients, low coronary risk patients, 1 week of triple therapy is probably okay. If you're talking about a high coronary risk patient, high thrombotic burden, small vessels, long stents, I think going for 1 month of triple therapy is still a good option. Most important is do not go above and beyond 1 month. I think 1 month, there's hardly any evidence to continue aspirin above and beyond 1 month. So after triple therapy, you drop the aspirin and you go with NOAC plus a P2Y12 inhibitor up until 6 months or latest 1 year. And that's also very important. Once you enter the chronic phase of coronary artery disease, so the chronic coronary syndrome situation, NOAC as a monotherapy is the therapy of choice. We do not need to, and we should not, combine this with aspirin. I'm saying this because we do see this still in daily clinical care quite sometimes, that people have had an infarction, I don't know, 3-4 years ago. They have atrial fibrillation. They are on a NOAC for atrial fibrillation, and they are still also on aspirin for the coronary artery disease. We can drop aspirin in almost all patients, latest 1 year after the event. We have good data to indicate that if we add aspirin in that situation, we only increase the risk of bleeding and we don't gain anything in terms of efficacy. Of course, bleeding is the main fear, not only in triple therapy, also overall. And the question always comes up, what do we do if it bleeds? Now, this is a very busy slide from the EHRA practical guide, and I'm not going to go through it in detail, just some important pointers. First of all, we need to assess the type of bleed. If we're talking about mild bleedings, we do not need to stop the NOAC, at least not more than 1 dose. The reason why we put this in here was because this is, again, a good opportunity to check if we're doing the right thing. Is the patient on the right NOAC for this patient? Or could the patient be on a more suitable NOAC? I've given one example earlier, there are other examples. Secondly, always look why there is a bleeding, because many bleeds can and should prompt further follow-up. If somebody has an easy nosebleed, that can usually be treated. If somebody has a gastrointestinal bleeding, we need to look for the reason for it. If somebody has a hemorrhoidal bleeding, that can usually be taken care of. Usually people bleed for a reason. So those two things are extremely important. Check for the reason and check if the patient is on the right NOAC. Then once we come to non-life-threatening major bleeding, you can bring in all of your supportive measures, fluid replacement, stabilization, transfusion if need be. And really only when we come to life-threatening or bleeding into critical organs or critical sites, this is when you pull out the big guns, right? So essentially the direct antidotes, if you have them available, iricizumab and andexanet alpha. If you do not have these available, we now know today that also PCC and activated PCC do work in these patients. They do work. They're not as elegant as the direct antidotes, but they do work, with the exemption possibly of intracranial hemorrhage. And I would just want to briefly take 1 minute to touch on the issue of the antidote, because this is something also that in the beginning of the NOAC era, we were quite afraid. We felt that we exposed these patients to a risk because we give them a drug that we don't have a direct antidote for. By that, of course, we forgot that we also don't have a direct antidote for warfarin. We don't. I mean, we have vitamin K, but that takes about a day until it works. And we have factors, PCC, but these are not antidotes. These are procoagulants. And as indicated, we now know they also work in NOACs. So having an antidote available is definitely a good thing. I'm showing here the data from the reverse AD study. This is for iricizumab, which is the antidote that is for dabigatran. And I think it is fair to say that iricizumab is probably as close as you can get to a perfect antidote. It works very selective. It works extremely well. You can see this here. Group A were patients with a bleed. Group B were patients who had to undergo emergency surgery. And you can see if you give iricizumab to these patients, you essentially take out the dabigatran from the equation, from the blood immediately. So their thrombin time and also their dabigatran levels normalize completely. They have no dabigatran, free dabigatran on board anymore. So it works extremely well. However, if you take a look at the patient outcome 30 days afterwards, over 12% of them have died. And at 90 days, almost 19% of them have died. And this actually looks very similar with andexanet alpha for the TNA inhibitors. So what does that tell us? Well, first of all, it tells us having an antidote available is a good thing, no doubt. It also tells us, however, that if you have a patient on NOAC therapy who has a life-threatening bleed, which is rare these days. It is rare. It's much rarer than under warfarin. But if it happens, then there is a certain risk that for these patients, the outcome will not be good. And this is the case even if you have an antidote available, no matter which one it is. And what this means in terms of practical issues is that I would not use the mere availability of an antidote to choose one NOAC over another, no matter which one it is. For certain patients, this may be quite useful, and for certain patients, it may play a role. But I would not use this as the only argument to give a drug that is possibly not suitable to a certain patient. Example, we can use the same example as before. If you have a patient, I don't know, 80 years old, creatinine clearance 32 milliliters per minute, I would not give that patient dabigatran from a practical perspective. There's a certain risk that this patient will accumulate the drug. There's a certain risk that your creatinine clearance will fall even below 30 with an even bigger risk of accumulation. And if this patient bleeds, there is a good chance that things will not end well, even if I have an antidote available. So this is really something that factors in, but it's only one piece of the puzzle when I decide which patient should receive which NOAC. And of course, one of the bleeds that we're frequently dealing with is gastrointestinal bleeding. And just to briefly show these data here, because this was in fact something that was more frequently with edoxaban than with warfarin. We have to mention, though, that the warfarin-treated patients in the trial were extremely well controlled. Over the entire trial, the time in therapeutic range was 68.4%, which is much higher than what we usually see in daily clinical practice. And these patients had a 20% lower risk of GI bleedings than those on edoxaban. However, if you take a look at the most relevant type of bleedings, and that's the fatal GI bleedings or the life-threatening GI bleedings, and those are in red and in pink here, you can see that there was no difference between the two. And in fact, numerically, it was even less with edoxaban. So this brings us to the two concluding slides, and that's what I already mentioned earlier. No matter which high-risk population we looked at, elderly patients, increased risk of falling, renal insufficiency, and so on and so forth, both the efficacy and the safety of edoxaban was better, at least as good, if not better, than with warfarin. And like I said before, this doesn't mean that we shouldn't treat the low-risk patients with it, but we definitely also have a very good option for the high-risk patients, both from an efficacy and from a safety perspective. Of course, the most important thing is that people take their drugs. Drugs don't work in people who don't take them. That's an old wisdom, but it's just as true. So we need to take advantage of all possible actions that we can in order to try and keep people on their drugs. Well, of course, we need to educate patients. We need to involve family members. Pill organizers are a good thing. And in some patients, the fact that certain two drugs are once daily may be something that resonates with people, that they like. And so we can take advantage of that as well. So in conclusion, dear colleagues, I think what's pretty clear is that NOACs are the standard therapy for stroke prevention. In 2021 and also now as we enter into 2022. It's based on a number of high quality randomized clinical trials, and it's been confirmed in a host of observational registry data. However, what is just as true is that we need to individualize therapy. There is no one size fits all NOAC, and there are many aspects to consider when we ask ourselves which NOACs we should use. And today, of course, as indicated, we have focused a bit on edoxaban. I think we have seen that edoxaban is a very safe, but also a very efficacious option for a large proportion of patients. It has a low potential for drug-drug interaction, as we have seen, less than 4% CYP3A4 dependency. It's the only NOAC that was prospectively tested to be dose reduced with certain co-medications. And we saw very consistent findings, even in the high-risk populations that we have talked about. And again, the once daily dosing may be quite convenient for many of our patients. And with this, I would like to finish, and I would like to thank you all very much for your attention. I'm very happy to tackle any questions. Thank you very much indeed.
suallar ala bilərik.
I have a question for you. In patients with middle to severe, mitral severity patients and patients with bioprothesis, what about the NOx usage in this type of patients?
Yes, very, very good question, very relevant question too. So this term non-valvular atrial fibrillation is not a good term, as we all know, but this is what is written in all of the labels. It's very important to realize that the only patients that were excluded from the trials were patients with mechanical heart valves and patients with moderate or severe mitral stenosis. So in those patients, currently, we can and should not use NOACs. It's particularly true for mechanical prosthetic valves. For the moderate to severe mitral stenosis, I'm not as convinced. It's clearly off-label, but there are some data that indicate that NOACs should also work in these patients. And from a pathophysiological point of view, I don't know why they shouldn't work. It's just that it's off-label and they were not included in the trials. For the question that you mentioned, so patients with mild mitral stenosis, it's not a problem. These patients were included and they can be treated. And patients with bioprosthetic valves, there were actually a couple of hundred patients included in the Aristotle trial with apixaban and also in the ENGAGE-AF trial with edoxaban. And to make a long story short, also these patients can be treated with a NOAC. In the meantime, there has even been a dedicated trial with bioprosthetic valves. That's the RIVER trial with rivaroxaban, which has confirmed these findings. So mild mitral stenosis, bioprosthetic valves, not a problem, we can use NOACs.
Yeah, Professor Steffel, thank you for your excellent presentation. My second question is how last year Brazilian
I have a little bit of a hard time understanding. I'm sorry.
Last year, South American scientists published one trial that's bioprosthetic valves. After 6 months, they showed that the NOACs is safe to use after 6 months. But what's your opinion? Early postoperative 6 months bioprosthetic valves.
That is a very good question indeed. I think the trial you're referring to is the RIVER trial with rivaroxaban, and in fact these patients were also included even early after the operation, even sometimes below 3 months. But it was not a lot of patients. It was not a lot of patients. So currently what I recommend is in the first couple of weeks to months, I would probably stay with warfarin, just simply because we have more experience with it. However, then after 3, definitely after 6 months, like you mentioned, I think it is fair to switch to a NOAC. And given the long-term efficacy and safety, I would recommend to switch over to a NOAC after 3 to 6 months. But in the early phase, I would stay with warfarin.
Thank you. And second question, with your presentation last slides, you showed that edoxaban GI bleeding total is 20% higher than warfarin, but in life-threatening GI bleeding is similar. How do you explain this result? It's related with GI pathology or edoxaban pharmacokinetic?
Yes, also that is a very good question. The reason why we are seeing this probably is because when we give edoxaban, it is an active anticoagulant. So even if there is a small erosion somewhere on the surface of the stomach or the intestines, we have an active ingredient passing by, and therefore even small bleedings can occur easier than if warfarin passes by, because if warfarin passes by, obviously nothing is going to happen because it only works systemically and not locally. So this is kind of the explanation that we have. There are some other examples where this explanation doesn't work, right? Because there was also an increased risk of GI bleedings observed with dabigatran, and dabigatran is a prodrug, so it doesn't work locally. On the flip side, there was no increase in GI bleeding observed with apixaban, and apixaban should have that same effect, right? So it's not completely consistent, but this is kind of at least how partially we explain it. I think the most important take home from this is we do not need to be afraid of severe GI bleedings with edoxaban because they appear at a similar rate than with warfarin. And all the others, non-severe life-threatening types of GI bleedings, you know, it's always an opportunity to check what's going on. Because I think all of us, we have in our years and decades of medical practice, we have diagnosed people's tumors by starting anticoagulation or by starting dual antiplatelet therapy. I can remember a good handful of patients in whom I have started anticoagulation and in whom we detected a tumor because of that. So I think that's the take home.
Dear Professor, thank you very much for your presentation. I hope that the next time you will be here personally. My question is, in post-PCI patients, you after a certain time you change to NOAC. And my question is, okay, we have two antiplatelet medications. So in which period, which one should be stopped? And do we have trials that showing in which antiplatelet medication, in which time should be stopped? And then proceed with NOAC.
Yes. So basically, that's a very good question. And indeed, I'm also looking forward to meeting all of you in person at one stage, hopefully sooner than later. But the question is a very good one, because we do not know actually what is better, if we stop aspirin or if we stop the P2Y12 inhibitor. The only thing that I can say in terms of recommendation is that in all of the trials, aspirin was stopped. And this is why we recommend for aspirin to be stopped. But I'm very honest with you, we do not know. We do not know the correct answer to this. And there is a certain risk of clopidogrel resistance, as we all know. And so it may be that some of these patients we are exposing to a higher risk. And in the same way, I think we also do not know whether the combination of any other P2Y12 inhibitor would be better. So we do know that from the majority of these patients had clopidogrel as the P2Y12 inhibitor. But there were some patients who also received ticagrelor and very few patients who received prasugrel. So if we compare the patients who received ticagrelor, they did have a higher incidence of bleeding in the trials. However, and that's interesting, they also had a higher risk of ischemic events. So we need to be careful when we interpret these data, right? Because there were not many patients and it was not randomized. So it may well be that the higher risk patients received ticagrelor instead of clopidogrel. We need to do a good prospective trial in order to find out. In our EHRA guide, however, we do open up the possibility to put people on even on ticagrelor in this context, right? The very lowest line that you saw. But we need to tell patients that probably there is a certain increase in the risk of bleeding. But if you as an interventionist, you really feel that these coronaries are ugly and it was an ugly acute coronary syndrome, then even reverting back to ticagrelor is an option.
Thank you, Jan, for such interesting presentation. I'm a cardiac surgeon, and that's why my question is about how do you think about in mitral valve repair surgical patient?
Very, very good question. Very good question also. To make the answer short, very similar to bioprosthetic valve implantation. I usually go with the recommendations of our surgeons. So if they say, I want this patient on warfarin for 3 months, then I go with that recommendation. Same if they say, well, probably better for 6 months. But afterwards, it's fine to switch these patients over to a NOAC. Absolutely. And again, these patients were included in the ENGAGE-AF trial, also some of them in the Aristotle trial. So we do have some evidence for mitral valve repair patients.
One question. In patients with peripheral arterial diseases, do we have any superiority of NOACs?
That is a very good question, and we need to clearly separate two situations. The one situation is patients with atrial fibrillation. Now, if we have people with atrial fibrillation, peripheral artery disease patients were included in the NOAC trials, but not to a huge extent. Not to a huge extent. Everything that, because these are, as you know, as I think we all know, these are usually amongst the sickest patients. So we did not have many patients with peripheral artery disease. But from what we have seen is that the benefit in terms of efficacy and safety overall also translates to patients with peripheral artery disease. Now, just for completeness purposes, for patients without atrial fibrillation and peripheral artery disease, of course, we have very good evidence from the COMPASS trial, right, with very low dose of rivaroxaban, so 2 times 2.5 milligrams of rivaroxaban added to aspirin. So this is a very good option for many patients with peripheral artery disease. But it's extremely important to remember that this is only for people without atrial fibrillation, right? Because the 2 times 2.5 rivaroxaban is not the stroke prevention dose. It's the arteriosclerosis dose, if you like.
Thank you, Professor, for your presentation. What would you do in patients who are on dialysis and with AF?
Yes. That's all. These are all very good questions indeed. And, you know, we'll have to be honest, first of all, that on dialysis, we don't have any randomized trial data for NOACs. There was one trial that was started and which was unfortunately prematurely terminated because it couldn't recruit enough patients. Then there was a second trial, which I think is still ongoing in Europe, in Germany primarily, where hopefully we will have some data during this year. But other than that, we don't have any data, any outcome data for NOACs on dialysis. Now, what we also have to say is we also don't have any outcome data for warfarin. There's not a single randomized trial for warfarin versus placebo versus aspirin versus anything in patients on dialysis. It's quite a shame, actually, because there are many patients like that out there, but so far we as a community have not been able to come up with a good outcome trial. And right now it looks as if we're running into exactly the same problem with NOACs. So to make a long story short, we don't know. The one thing that we do know is that warfarin is not good for the kidneys. So not only from a bleeding perspective, but also from a kidney function perspective, it is not good. And there are certain situations where NOACs may be considered in patients with even with dialysis. Now, of course, this is entirely off-label. We need to tell the patient, we need to document that we don't have any data. Sometimes there's even a problem with payers, so the insurances won't pay for it. And the one thing that I would recommend, though, in these situations, and this is also true, by the way, when we're talking about stage 4 or 5 chronic kidney disease, so pre-dialysis, I would recommend to every once in a while, at least in the early phase, check a NOAC plasma level. Now, of course, this is also off-label because we don't have any target values, if you like, for NOAC plasma levels, but at least we can say that the level that we measure is somewhat in the range of what we usually observed in the trials. And I think this gives us a little bit of reassurance that what we're doing is probably not entirely wrong. But we need to tell patients, again, also that this is something that is off-label and that we don't have outcome data for. We talk about this actually quite extensively in our guide, where we also have a nice table with all of the expected trough levels and also peak levels for NOACs.
Gözəl təqdimatınız üçün təşəkkür edirəm.
Thank you very much for your presentation. You know that Okay, the procedure Osaki in aortic valve, it was intensified in last decades. What do you think about the use of NOACs in these patients?
And the procedure of what? I apologize, I didn't understand correctly.
Ozaki procedure.
Ozaki procedure. I'm very honest with you. I'm not aware. And I'm not a cardiac surgeon. Maybe we can ask our colleague in the room. We do have some data for aortic valve repair. Be it, for example, with the Ross procedure, even with Tyrone David procedures, we do have some data. And in these situations, again, it's similar like for the bioprosthetic valves or the mitral valve repairs. In the early phase, I would clearly recommend to stick with the warfarin, but afterwards I would switch to NOACs.
Ozaki procedure is the same procedure as biological valve replacement because autologic pericard we use in Ozaki.
Okay, good. Perfect. Thank you very much for clarifying. In that case, my answer was correct. I would recommend to do the same as for bioprosthetic valves in the mitral position. Actually, the risk is potentially or factually even less in the aortic position because there is a higher blood flow velocity, so it's totally feasible.
Gözəl, maraqlı çıxışınız üçün təşəkkür edirəm.
Thank you, Professor, for your interesting presentation. My question is a bit far from the cardiology, but actual question. It's dedicated to COVID patients because we use the thromboembolic prophylaxis. As I know, the rivaroxaban in dose 10 milligrams is been approved as prophylaxis for thromboembolic events in COVID patients. Do we have the same recommendation for edoxaban? And second question, and the timing. So when we need to start and how long we need to give?
That is a very good question. It's a very good question, and it's not entirely solved. We have to be honest. I mean, the evidence, what we thought almost 2 years ago when the pandemic started, and what ultimately turned out in terms of evidence was not entirely congruent. So, At this stage, we do not have similar stroke prevention prophylactic, I should say, thromboembolic protection data or approval available for edoxaban in COVID patients. Now, with that being said, if somebody has a thromboembolic event and you want to treat that patient afterwards with COVID, then I would not see a problem why that shouldn't be done with edoxaban or with any of the other NOACs. But for the pure prevention dose, this is something that was not studied. This was not studied for edoxaban, so I think we shouldn't use it in this setting. And here's another important point, I think, about COVID patients. If you have somebody who comes into your hospital or that you treat on an outpatient basis who is already on a NOAC, for example, for stroke prevention, and this can be any NOAC, including edoxaban, there's absolutely nothing wrong in keeping the patient on that drug. I think it's especially important in this situation. And here, I do not think, no, there is no reason to switch that patient to any other NOAC. You can keep that patient on apixaban, on edoxaban, no matter what, even if they catch COVID. The only situation where I would stop it is if they really need to go to intensive care. So if they have multi-organ failure, of course, then is a situation where any NOAC should be stopped.
Güzel çıxış üçün mən də təşəkkür edirəm. Mən bir konkret situasiya üzərindən sual vermək istəyərdim ki, bilinən major qanama
One question. Okay, the question is individualized for you. The patient has major bleeding and also has the AF. Which medication you would use as personally?
That's a very good question. I think that the problem, of course, is that the main problem is that we don't have direct comparisons, right? So it's extremely difficult to answer. And there are many factors that come into play. If we have the high-risk patients, they usually have a high risk of stroke and a high risk of bleeding. Stroke risk and bleeding risk go alongside each other. With that being said, of course, like you mentioned, I mean, we have the patient in front of us, and it is very difficult to make a call, but we need to make a call. I think what we have seen is that in terms of efficacy, the NOACs are overall rather similar. In terms of major bleeding, further major bleeding, I think we have seen that in the high-risk populations, there seems to be quite a positive outcome for edoxaban and for apixaban, even in the high-risk individuals. So I think for many of these patients, this would be an option. Now, two things that are important. If somebody has had a major bleeding, like I said before, it's very important to go all the way and try and treat that, find out why it bled and then treat it. And secondly, also very important, just because somebody has had a major bleed doesn't mean that we can no longer anticoagulate that patient. Many patients in whom we find out why they bled and in whom we treat it, we can and should restart anticoagulation. Somebody that has a bleeding ulcer in their stomach, that's treatable, and we can restart anticoagulation. If somebody has had a hemorrhoidal bleed, it's treatable. Nosebleed, treatable. So I think that's very important. We sometimes seem to have that monosynaptic reflex that once somebody has had a bleeding event, we can no longer give anticoagulation, and that's not correct.
Thank you, dear Professor. Can we use restart again after mild bleeding?
Yeah.
Mild bleeding, edoxaban or any NOACs?
Yes, That's a very good question, and it depends on the type of the mild bleeding. If somebody has had, for example, a nosebleed, something like that, we usually recommend to stop for a day or to leave out one dose and then restart again afterwards. Now, of course, this, again, it totally depends on the type of the bleed, right? And I would definitely send these patients to a specialist and see why they bled, because they can maybe treat it locally. It's absolutely important to ask patients about these types of bleeds, because these are the type of bleeding events that they usually don't tell us about, but they just stop their NOAC, especially primary prevention patients, which are the majority, right? You know, they need to take their NOAC. They have not had an event, and it's primary prevention. They only see the negative effects, that they bleed when they shave and everything. So we need to actively ask them about that. And if they do tell us about it, then try and eliminate the source. But usually, to answer your question, one dose is usually enough for the vast majority of these types of bleedings.
Thank you very much.
Thank you, Mr. Steffel. We're grateful for your presentation, asking our question. We hope to see you in our country one day. Thanks a lot.
Thank you very much. Great pleasure. Thank you very much indeed.